that what would you want all of us in this room to do when we get back home and do our day jobs? Tash.
Okay, I think my talk was about cognitive impairment. I think what we should do is, in our areas, to make sure there is good communication between the osteoporosis services and other services such as memory clinics. Because if you can identify people who are early in their cognitive impairment, you can surely do something to prevent that fracture down the line. So I think, for example, people in memory clinics should be encouraged to do FRACs on their patients. They should be encouraged to do a medication optimization review to see if they're on drugs that might cause falls, to see whether they might need deprescribing. They should be encouraged to refer their patients for balance and exercise training, because we know that that's one of the most effective interventions to reduce falls, and systematic reviews have suggested fractures as well in the future. So I think we should go back to our areas and see if that link is happening, and if not, try and encourage them.
Thank you, Tash. Pass the mic, yeah. Eugene. One thing you would want us to do when we get back home to our day jobs?
Sorry, I was listening to the first question. I thought it was going to be Tash specific. So just quickly remind me.
Yeah, so one thing that you want us to do when we get back home to doing our day jobs, one important thing.
Okay, so I think the one message is, we can do something about this. So we sort of think that this is a big problem, it's a huge problem. You know, the financial cost, the personal cost of osteoporotic fractures is huge. FLSs are really a superb way of intervening, but relatively late in the condition. People have had the event. And prevention, as we've just heard, is something that could start much earlier, perhaps in pregnancy, in early life and so on. But for the majority of people that are out there now in their 30s and 40s and 50s, they're at relatively low fracture risk. But in 20, 30 years' time, there'll be a relatively high fracture risk. And that's why we picked an age-dependent threshold for the NOG guidance. So we wanted to pick up people who were at high risk for their age, so that they could be targeted for future prevention of higher fracture risk at older ages. So the bottom line is that we can do something. We need to examine how we implement this sort of intervention, because risk assessment is getting increasingly easy, but the impact on workflow downstream is the thing that we need to ensure is in place. Because at no point, as Kazim showed in his excellent presentation, whenever they picked up all of these vertebral fractures, the rest of the service couldn't handle the extra workload. So we need to be sure that what we put in place is timely, it's supported, it's resourced, and it's effective. So, a bit of a long message, and you're all half asleep now, so that's okay.
Thank you, Eugene.
Yeah, I think for me it would be a plea to go and speak to the women in your lives, talk about the effect of menopause on their bones, and to have some conversations, particularly with if you've got adolescent daughters, teenagers in your life, and for those who perhaps about to enter the perimenopause, just ask them, raise awareness whether they've had a consideration about what their bones, what will happen when they reach the menopause.
Thank you.
I think mine's going to be short and sweet. Ensure that public health are engaged in medical pathway development, and make sure that those pathways do whole pathways that start at primary prevention all the way through to good clinical care.
Thank you. Any questions from the floor? Gentleman back in the white and then the lady in the front. Oh, I'll start the lady in the front. She's got a microphone in her hand. So
Right. Stephanie Williams, I'm an SCS doctor of health. I wanted to ask about polycystic
question, and I think that's the same with a lot of the guidelines when we look at the College of Sexual and Reproductive Health, when we think about contraception, we think about mental health, we think often about pain and managing symptoms. But you're right, you touched upon polycystic ovarian syndrome, and often what we advise is the use of things like combined oral contraception pills. And I think there's increasing evidence thinking about the pros and cons of ethinyl estradiol, which is in the COCP, compared to the 17-beta estradiol that we see in HRT, and the risks and benefits. But actually, I think it's the same that we'd be having with women at different points. Contraception is important. It's thinking about their bone health. It's thinking about moving, exercise. We know from data a lot of girls stop exercising in their adolescent teenage years, so it's encouraging them to continue to be moving and being active and thinking about diet. So I think it's multifactorial in terms of thinking about bone health and making sure that we're having those open conversations earlier on. But you're right, PCOS I think is one area that will come on a long journey in terms of managing it holistically.
Very much. A gentleman back.
Yeah, thank you. Kevin Duff, my name is Kevin Duff, I work in CTMUH Media Strategy and Transformation. It's a comment more than a question or observation really on Professor Massoud's comments around the link with dementia and with memory clinics, etc. I'm just wondering at a national level, at the Welsh Government level, whether there's been any thought really of those links, because we've just had the dementia strategy or dementia action plan consultation released, the consultation ended at the end of March. And that's really the plan that will drive dementia services over the next 4 or 5 years across Wales, including memory assessment services, services for mild cognitive impairment, post-diagnostic services, etc. And I don't recall, I didn't look at my phone whilst we were talking, whilst the presentation was going on, I don't recall any sort of clear mention in there of the risks and the links over to bone health from dementia. And I'm just wondering if there have been any comments made by that level, and where we really need to pick up that interconnection at policy level and national level. And if I could, sorry, stick one more comment in as well, particularly in relation to Dr. Munro's talk around the huge benefits around exercise, resistance training, etc. We have a capital audience, as you said yourself. The NHS and the public sector, to say, is a majority employer within Wales. We have a capital audience within our staff, and I'm just wondering if there would be any thought or any significance in an approach or benefit from an approach of having an occupational health approach within our workplaces and building in sort of that exercise program into our everyday working processes, 20 minutes twice a week of resistance training activity, to get people engaged in that, get their thinking around it, rather than just giving free gym membership or something like that down the road where people will never go to. So 2 points.
Good. Thank you, that's great questions. What I'd like to do is refer you to the World Falls Guidelines. They were published in 2022. There were 12 working groups, and one of the working groups, I think from memory, was working group 5, which looked at people with cognitive impairment and falls. And the working group basically did a huge literature review, systematic review, and it was done in the proper way. These reviews should be done with grading of evidence, what's expert opinion, what's grading. And they came with some recommendations. And it was clear that the literature suggested that exercise in cognitively impaired people, mild to moderate cognitive impairment, can reduce falls and possibly fractures. In severe dementia, it possibly doesn't. Okay, but certainly mild to moderate, it does work. So that I think you can see there's a huge link from the paper in Age and Aging to the whole documents that were done to come up with those recommendations. Another recommendation was that And in the patient perspective, but also the caregiver perspective, and building an individualized plan into exercise is really, really important. Because if they have buy-in from the patient and their caregivers, that really does help in making sure that they continue with the exercise. So for example, you can have group-based exercise, or you might have individualized home-based exercise. And a lot of it depends on the patient perspective or the individual's perspective on which one they might want to do. And also the caregivers. There's issues around transport. Can you get the individual to the group-based exercise? It may be possible, it might not be possible, depending on whether they've got transport and what the local transport buses services are, for example. So I think I would definitely recommend you to that document. You can just go to Google and type in Will Falls Guidelines, and there's a link. You can take you through it, and then you can look at the evidence for that.
Right, so I think you two might have a big lunch discussion, actually, put you two together then. And one final question for the gentleman.
Question for Tracy. So one of the main issues we have about inequalities is actually displaying the data. So at the moment, the FSDB has no live chart to show how inequitable or equitable your care delivery is in terms of, say, treatment recommendation or one of them. It showed his dashboard. Does Wales have an inequality by hospital chart or dashboard? Because unless you provide that data live, sites aren't going to be able to reduce or even know how inequitable their care is.
Yeah, I think, no, we don't. And I suppose this is the challenge, isn't it? And this is about understanding the stuff that's missing from our data. If we continue to only focus on the stuff that we count, we will almost miss the stuff that counts. And I think that's the challenge for me. The data landscape, we've got a lot of data. It's not necessarily freely accessible. We're not in a position that we can link data to understand the patient journey. We also need to be thinking about if we're truly going to get into the business of wellness rather than treatment, then we need to start and have a focus on people, not patients. So I think there is something about we need to look into our communities to give us that inequalities benchmark, not necessarily in the rules of healthcare. And I think working across healthcare, public health, we can get to a baseline point.
I think Inda wants to come in.
I just want to follow on question with answer to that. Yes, we don't have the data as we speak, but practice fracture example which I showed today, it does have live data for the last 10 years across every health portal rates, and just click a few buttons, you're able to see most to least applied. You're also able to see rural and urban classification. You're able to see outcomes, gender, etc. based on that. So that's the work in progress. That's our CMO want us to look at the health outcomes in the wider respects. So we do have for practice fracture and work in progress with digital healthcare rates. I think in a matter of 6 months we'll have for all fragility fractures. So maybe next time. Thank you.
Are there any more questions from the floor? Yeah, this one.
Hi, I'm Amanda. I'm a pharmacist at Prince Charles University of London. I often get asked, although no, I'm Frax, acknowledge daily intake of glucose guides. What about people who have frequent short courses? Is COPD patients, should we be risk scoring them as well?
Yeah, that's a good question that we don't have a definitive answer for. But we certainly know that patients who get frequent short-term courses, if you look at the cumulative exposure over a year, for example, then the threshold that was set whenever we put the yes or no answer into Frax was 5 milligrams of prednisolone for 3 months or more. And of course we do that over a lifetime. Lots of patients who glucocorticoids come above that threshold. But we generally, in our clinical practice, do it over a year. And it's patients who are getting that sort of exposure over a year. We're currently doing an update on the Frax tool in terms of the number of cohorts that we had. Whenever we built Frax, we had access to about 11 cohorts with about 50,000 people in it. Now we've got access to 64 cohorts with 2 million people in it. So there's a lot more information about
stand in the way of lunch. I think we draw this session to a close, and thank you very much for all our panel members for excellent talks. I can actually back there.